done 3 months of GP and now he thinks he knows all about it.
No, it's fine. We'll get some Imperial Med students to correct them. At what point when you become a consultant, do you start calling other consultants by their first name? Do you just phase it in, or do you just go, okay, I'm going to
just pull the pin out and see what happens and leave the room? It depends largely on how well you know them. I guess age comes a bit into it as well. If you've previously worked with them before and they were your you're a registrar when you're a SHO and so on, it makes it a little bit easier to do that. If they were a similar age to you, it's easier. I must admit, most of them I call by my first name, except those who are a lot more senior.
But so when you were like the fellow, the bariatric fellow, you called them all by like Mr. or Miss, right?
Oh yeah, I did.
And then
unless they told me, you just call me whatever. Yeah.
When you became a consultant, did any of them come up to you and be like, "It's okay, you can call me by my first name"?
A lot of them did. Didn't they? It all does.
That's I was just wondering how quickly does that switch happen, or does it just happen like instantly, where you're like, yeah,
again,
first name terms, we're peers now.
It depends on the personality of both sides, I guess.
Fine.
How comfortable you are, and how open and comfortable they are. It depends on the personal relation.
Fine. Okay. I was just curious.
Many of them, for most of the people that I work with, I don't think many of them would mind being called first. Yeah. I don't think I would ever would.
No, I mean, except for you, who gets called professor a lot, but that's just my abuse.
But that's not a title that I'm looking forward to, especially coming from you, Joe.
Right, so I'm stepping in for Professor Ali, who unfortunately can't be here today because
I don't know if that's better or worse. Okay.
He's getting a double kidney transplant, I believe.
Good to be back, and we're going to go through something that concerns a lot of trainees and candidates when they first start preparing for the examinations, and that is definition. And you will be asked definitions in your subspecialty viva, and your critical care, and your general surgical one, academic. So we're going to go through some clinical ones, just to make you a bit more confident.
Test me on my definitions for the FRCS.
We'll probably need to cut all of that out, but we'll see how we go. But it's really important that you have a very nice, crisp, concise definition that you can say in 10 seconds, because a lot of the stations usually open with something like that. So you'll come into your critical one and they'll say, "Tell me what do you understand of sepsis," or something like that. And it could be very off-putting. And if you're spending 35 to 40 seconds in a 5-minute station just answering your one question on definition, it's too much time. So you need to get a nice, crisp, kind of smooth way of saying things. Definitions we're giving you now, you don't have to say it exactly in that way, but they do need to contain the core elements of what we're saying.
I'll ask you some, and then you can explain them to me, because I'm no longer surgical. So okay. That'll be a nice little challenge for you. What's an abdominal compartment syndrome?
Abdominal compartment syndrome, as defined by the World Society for Abdominal Compartment Syndrome.
Wonderful. That sounds like fun.
It's an increase in intra-abdominal pressure beyond 20 millimeters of mercury that also has accompanying end organ dysfunction. So your definition is going to be, as per the World Society for Abdominal Compartment Syndrome, it is an increase of pressure above 20 millimeters of mercury and end organ dysfunction. Normal abdominal pressure is less than 5.
When you say end organ dysfunction, other than like urine output dropping, what else would that be?
So respiratory, so it could be bowel, it could be urinary.
Achalasia.
Achalasia is one for your upper GI surgeons out there. Achalasia is a dysmotility or a neuromuscular dysmotility disorder characterized by failure of propagation of muscular contractions of the esophagus, a failure of relaxation of the lower esophageal sphincter, resulting in a combination of dysphagia and reflux.
You've got AKI on here. Man, that's med school level. Surely you don't need to know the definition of AKI.
It comes up very often. So AKI, or acute kidney injury, is defined by the KDIGO criteria.
Yeah.
So that's the kidney disease improving global outcomes, KDIGO. And it is several things. So it's a creatinine more than 26.5.
I think it's 26.2 actually. I'm pretty confident it's 26.2.
You hadn't even heard of this because you thought it was his medical school. He's done 3 months of GP and now he thinks he knows all about it.
No, I'll have a look.
There are no geeks here. It's all very cool. 26.3, is that right?
I could be wrong. I think it's 26.2. I'll double check.
Okay, so we're going to go through the 3 things that define acute kidney injury. So acute kidney injury is defined by a creatinine more than 26.2,
I think.
in the last 48 hours. a creatinine rise more than 50% from this baseline in the last
7 days.
7 days, and urine output dropping below
I think it's 0.5 ml per kilo.
exactly in the last 6 hours. So that's the one we know. So just to recap, AKI, or acute kidney injury, as per the KDIGO criteria, is a creatinine more than 26.3 in the last 14
Two, mate, two. It's fine. We'll get some Imperial Med students to correct that.
26.2 in the last 48 hours, or a creatinine rise more than 50% in the last 7 days, or it's a
Urine output of
less than 0.5 mils per kilogram per hour over the last 6 hours. Those 3 things. Okay, excellent.
So you got ARDS. Tell me about ARDS.
ARDS is important. So ARDS, as per the Berlin criteria in 2012, is the acute respiratory.
The D stands for distress, mate. Point out.
I thought you were going to say something. As per the Berlin criteria of 2012, ARDS is acute respiratory distress syndrome, and is categorized by.
So I have a definition, but it's not your strict definition.
Okay, what's your definition?
My ARDS definition is essentially pulmonary edema secondary to a non-cardiogenic cause.
Yeah, close enough. So the answer you want to give is this. ARDS, as per the Berlin criteria, is an acute respiratory distress syndrome that's caused by acute inflammatory injury to the lungs, resulting in reduced lung compliance, microvascular and microalveolar permeability, increased permeability that reduces compliance, and ultimately leads to pulmonary edema that's not cardiogenic in its origin.
Barrett's esophagus.
Barrett's esophagus, for your upper GI surgeons out there, very important. Ultimately, it's a change from one type of epithelium to another. So normally, what's the epithelium you get in the esophagus?
It's non-keratinized squamous epithelium.
So what you want to say, it's a condition in which there is a change from the normal squamous epithelium.
Non-keratinized.
Don't worry about keratin. Lining of the esophagus being changed to a different type, which is the
Columnar.
simple columnar. Exactly. Okay. And it's usually due to
Chronic reflux.
Exactly. So Barrett's esophagus is a condition which occurs in chronic reflux and is characterized by a change from the normal squamous epithelium to a columnar epithelium in the esophagus. And it is a precursor, or rather, increases the risk of esophageal cancer. Fine.
What's brainstem death, other than what Moali has on a... what Moali is suffering with?
So brainstem death is an irreversible loss of consciousness and irreversible loss of the ability to breathe. Now, general anesthetic would tick half of those 2 boxes, i.e. you don't breathe unless the machine's breathing for you, and you're not conscious. But it's not brainstem death because it's reversible. So brainstem death is an irreversible loss of consciousness, irreversible loss of ability to breathe, that is tantamount to the death of that person as an individual. That's what you want to say.
What's DIC?
DIC is the pathological activation of the coagulation cascade due to a variety of causes, but usually trauma or inflammation, that results in a state where there's paradoxical coagulation and bleeding.
So what's hepatorenal syndrome?
All you need to know is that it's acute kidney injury due to hepatic failure, essentially advanced liver disease, whereby the cause there's no other cause for it, so not medication or other causes of renal failure.
Hernia.
You should know.
Oh yeah, this one. Yeah, it's the
even the medical school that you all should know hernia, right?
It's a protrusion of an organ or a viscus where it moves from a normal to an abnormal position through a surrounding area of weakness.
Excellent. Okay, yeah, exactly. So it's a protrusion of an organ or tissue through an abnormal opening in the body wall where it's usually contained, so where it shouldn't be. That's what it is. Okay.
Hyperkalemia.
You should know this as well. What's hyperkalemia?
It's different to the definition you have.
Hyperkalemia is a potassium more than 5.5. There is no other definition.
It's 6.5 if you speak to a renal consultant. That depends who you speak to.
Yes, but equally, a creatinine of 900 is usually probably just Tuesday for them. But for the purpose of this exam, apologies to our renal physicians, for the purposes of this exam, it's more than 5.5. That's what we're going to think is hyperkalemia. What's hypokalemia?
Hypo is less than 2.
Excellent. Okay, fine, so less than 2. Okay, what's hypernatremia?
So I think that's a sodium level of over 147, isn't it? 140.
Anybody?
So I'll tell you why.
Catch me.
No.
This guy's
Let me explain. So if you look at it, depends on the
You're
assay
right,
that they
it
used.
is-
It depends on the assay that
you're
they
right.
used. The old trust we used,
Yeah.
147 was the cutoff.
So there's a great deal of variability. Some trusts say 138. Some
Really?
140, yeah, so 144, 140. But just to have a single definition, certainly 147 above, it definitely will be.
I think, yeah. So some of these might be assay dependent, I think.
Yeah. Fine. Okay. Hypoxia.
So hypoxia is defined by reduced hemoglobin of over 5. Reduced hemoglobin of over 5, I think it is.
Yeah, that's part of it. But what's the definition we want?
So essentially, you're not getting enough oxygen, enough to cause end organ damage. Right?
Excellent. Okay, so you need a phrase to sum up that nicely. So essentially, hypoxia is a physiological state whereby inadequate oxygen is being delivered to meet the tissue demands of the end organs. That's it. And it usually is around what you're talking about. But ultimately, it's the end organ oxygenation and perfusion that's important. Good.
Fistula. No, I know this one.
Go for it.
It's an abnormal connection between two epithelial cells.
Excellent. Exactly. And it's often between vessels or organs or cavities. Okay.
Respiratory failure.
This one's a lab definition more normal. What's respiratory failure?
So I think if we're just going as broad as possible to encompass everything, it's going to be PaO2 less than 8.
Yeah, exactly. It's a PaO2 of less than 8 kilopascals is respiratory failure. That's the definition of acute respiratory failure or respiratory failure, full stop. Good. Sepsis. This is one that people trip over.
I think the definition of this has changed because our understanding of sepsis has changed.
Absolutely.
So it used to be SIRS plus
And a microorganism.
plus a sign of infection. It used to be like a source of infection plus 2 criteria of SIRS, but now I think it's a bit more global. So it's like a dysregulated immune response to a possible or likely source of infection, resulting in end organ damage.
That's it. Exactly. That's it for all the clinical ones?
I think that was good, actually.
Yeah.